And I will share my screen. Share screen. All right, there you go, Chris.
Perfect, thanks. So, yeah, a few weeks ago we presented on pulmonary emboli and an approach and algorithm to treating those patients. The more common consult we have been getting are for the high-risk submassive group, which presents some decision-making challenges, and that's really what we wanted to highlight today. So just as a refresher, massive pulmonary emboli and submassive, the differentiation is not really about clot burden per se, but more about the physiologic impact of the pulmonary embolus. So massive pulmonary emboli are those that are associated with sustained hypotension or hemodynamic instability. And submassive are split into two groups, high risk and not high risk. And that really is dependent on imaging and biochemical markers. So it is an acute PE without systemic hypotension, but some evidence of either RV dysfunction on echo or enlargement on imaging, and then an elevation of your biomarker, so BNP or troponin. And this is just a bit of a schematic demonstrating the spectrum that these patients present in. So the massive group is hypotension, but that can range from mild hypotension to hypotension requiring inotropes to that requiring end organ or demonstrating end organ dysfunction, all the way down to those people that have arrested and requiring CPR. And down the bar graph on the bottom, you can see that the mortality associated with thrombolytics or heparin only increases exponentially as you progress along that clinical spectrum. The submassive group, so the middle segment there, you can see are people that have RV strain and or elevation of their biomarkers. These people have a lower risk mortality with thrombolytics and heparin, and that is compared to the far left where you have, modern surgical pulmonary embolectomy. Most modern case series have a mortality rate in the kind of 10% range, 12% range. So this is how some of the decision making around what type of therapy is made in terms of risk benefit of the different therapeutic options. So the people, again, this is from the last presentation that we would consider for a surgical embolectomy. Those people with a massive PE, I think it's reasonable in those patients, particularly patients that have a contraindication to thrombolytic therapy. And the deteriorating submassive PE, so the people that have submassive PE but are gradually getting worse or rapidly getting worse and are a reasonable surgical candidate. And then those people with a right heart clot burden or clot in transit across the PFO, or those people that have failed thrombolytic therapy. We can have the next slide, Jeff. Perfect. So this is an algorithm. It does look a little complicated, but if we focus on the first orange box there, which is the submassive group, and those people that have are high risk, so have an abnormal RV and have some degree of elevation of their biomarkers. The next box down is do they have an absolute contraindication to thrombolysis? If they do, then you could consider either a catheter-directed therapy or surgical pulmonary embolectomy. And if any of those people get worse, then they shift over to the massive PE algorithm, in which case you can consider them. In general, the guidelines say if they have a contraindication of thrombolysis, but some of the conversation from last time is if they're a low risk surgical candidate, does a surgical embolectomy actually have a lower risk of stroke and perhaps a better chance of decreasing the risk of residual clot burden and chronic pulmonary hypertension in the long term. But the patient population we're talking about today is intermediate risk or submassive PE that is high risk based on biomarkers and echo. And we have, I think all of us on call have been getting more of these consults, and I think it's a good thing. And we're really trying to have this be a multidisciplinary discussion between the surgeons, the ICU doc on call, the emerge doc, and the interventionalist. But the decision making is not as straightforward as that algorithm shows, and that's really what we wanted to highlight today. So the first case is, I don't really know what we should do. The second case, surgery makes sense. The third case, you know, maybe we just got lucky with the path we chose. So I'll talk about the first case, and JF will take from case 2 on. So this was a 71-year-old gentleman who had a remote history of a provoked PE. He was no longer on anticoagulation, a reasonable number of other comorbidities, and had a prior peptic ulcer with an upper GI bleed when he was anticoagulated for his first PE, hemorrhoids, but otherwise a well-functioning guy, had dyspnea for 72 hours, presented to St. Joe's with his dyspnea. They performed a CT scan, which will show he did have elevation of his biomarkers, but was normal sinus rhythm in the 70s, normal tensive, and on room air. And the CT scan, you can see he has, you know, a large central clot burden, essentially occluding both main pulmonary arteries. You can also see on this scan his descending aorta. He's got calcium. He's got a lot of atheroma. He had clearly a fairly heavy burden of arterial disease, both in his coronaries and his aorta, which, you know, I think factors into risk benefit of a surgical intervention in a 71-year-old when you're talking about cardiopulmonary bypass, hypothermia with periods of circulatory arrest to perform an embolectomy. So all that factored into the decision making, and the fact that you go and look at the guy, he's sitting there in bed and emerge on room air with a normal blood pressure and normal heart rate. So it's hard to argue to take this person to the operating room and do a big operation with someone that looks that well. So what would you do is really the question. So he was seen by myself, by Mark Tushka and Emerge. There's a phone call to interventional radiology and a conversation with the Emerge doc. So between the 4 of us, we agreed that we should not do an operation. He was anticoagulated with heparin and transitioned to a DOAC. He did not get thrombolytics either because he had no, no tachycardia, no hypotension, was on room air. And with just anticoagulation, he never did require thrombolytics. He remained hemodynamically stable. He was admitted for 9 days, and that really was because of significant exertional dyspnea. And it took him 9 days to get to the point where he could climb the 17 stairs he needed to get into his apartment. But so clearly still functionally limited, though not oxygen dependent. And the natural history really of this is what is in question is, what will this gentleman look like 6 months from now or a year from now? Will he still be functionally limited? What is the residual clot burden that he is left with? And that answer is very hard to come by. So this is the conclusion of the first case, and JF will take it from here.
Yeah, thank you, Chris. So the case number 2 is one that, a little bit different. Mrs. R, so 73-year-old female, previously well, so a few weeks history of shortness of breath, and really presented to the emergency department. So slightly tachycardic, blood pressure was okay, but saturations were not great. So the 90% on 50% FiO2, and that fluctuated. The major risk factor that she had was really around obesity. Otherwise, nothing unusual on her medical history. And I'll show you the CT scan and you see what you see. I'll play this a few times because it is worth sort of noting. So the images are coming, and this is the pulmonary artery that you see here, and you see this large clot burden that obviously saddles across, and the clots are throughout the pulmonary tree. So clearly evidence of a very large, and I don't know if you noticed, but you're starting to notice, I didn't sort of scroll down, but the right ventricle is actually quite enlarged here. So there are some signs that this is certainly affecting her quite a bit. And these are still images of exactly that. You can see the clot burden in the main pulmonary artery here, and this is a side view of the actual pulmonary tree that's entirely covered with clot. And when that was done. So, the next is really about the ultrasound or the echo, and this is again worth for you guys to look at. They're going to loop a little bit so you get a chance to look at them better. I don't know why they stopped playing there. There we go, we're back. The image on your left is, you can see the larger ventricle is actually the right ventricle. It should not be the case. It should not be larger than your left. And if you look at the other image, the cross-sectional of the ventricle, the left ventricle is the donut here. It doesn't quite look like a donut. There's a little flattening of the septum, and you can see the RV is quite large here. So these are the kinds of things that sort of classify this patient on the submassive spectrum of sort of RV strain, RV enlargement, signs of not doing as well. So what would you do? And this is where, you know, there are some challenges here. It's a little bit more obese lady, started on heparin, did not clinically get better though on heparin and propionate anticoagulation over the first few days. And we decided that, you know, she would be the one that, given the clot burden, thrombolytics didn't really make sense, and operation made more sense given the large amount of clot in the main pulmonary tree. And you can see here the clots that were removed from the right side and the left side, and many of the branches involved. And so quite impressive in terms of clot burden and where we're able to remove. And this is a ruler that you can see here, obviously showing you 15 centimeters. I mean, these are large amounts of clot that we took out of the pulmonary vasculature. And the hope, obviously, to make her clinically better. So what was her course in the hospital? Surprisingly, was not as easy as I thought it would be for her. So the surgical part was, you know, reasonable, and the early recovery seemed reasonable. But, you know, she required oxygen therapy for 4 weeks with easy desaturation, difficulty still with that chronically, despite pretty significant improvement on CT imaging. But she continued to have pretty significant residual right heart failure and right heart strain, and was seen by our heart failure cardiologist, Dr. Noel, with some suggestions. And eventually over time, you know, these things sort of gradually better. So functionally, I think she is better, but only time will tell us. Not to say that we made the wrong decision. You know, I think she was short of breath at rest on lots of oxygen in bed. She clearly went from someone who was able to do everything to nothing. So I think we've improved things, but I'm surprised at how much residual disease, or makes you think perhaps of a chronicity here that we missed. So that's the case number 2. In our case number 3, just again to illustrate, so within a few weeks again, so a young man, Mr. B, 60-year-old gentleman, gets CABG surgery, uneventful, no major risk factor, received Plavix, aspirin, heparin, as you might imagine, in his course in hospital. Post-op day 5, you know, complains of calf pain and some calf swelling, and our nurse associate quite astutely, you know, clinical exam, swelling. She's concerned. It was a vein harvest side scan for DVT, and it was found to positive, and appropriately started on IV heparin. So a great catch from a clinical point of view from our team and our nurse associates to really treat this patient appropriately. And unbeknownst to us, on day 7 post-surgery, so 2 days after, had been fully heparinized for 2 full days, acute onset of shortness of breath, not feeling well, saturations in the 70s to 80s on 100% FiO2, heart rate that jumped from the 70s, you know, nice sinus rhythm, to above 100, sinus tachycardia, with a reasonable blood pressure. Obviously, this gentleman is 7 days after open heart surgery, and this is his CT scan. And I'll play that again so that it's gonna, whoops, sorry, I'm shifting down. So as it's shifting down, you're gonna see the pulmonary artery come up in a second. So it's right here. The clot doesn't cross the midline, but there's a large burden of clot here on both sides. So pretty impressive clot again on this patient. And this is the kind of clot you see right here, involving a little bit more distally, and here's some other views of it. So again, large clot burden. What do you do? So obviously thrombolytics are not part of the story here. So assessment of our right ventricular strain. So he actually looked surprisingly quite good despite low saturation, but just a scary event on a Sunday morning. RV and CT and echo actually looked okay. So what are my options? You know, I initially chose to take into the intensive care unit for us, you know, proper monitoring, and how face max oxygen transferred to an OptiFlow at 100% with 50 liters. And a little bit of time really got us to where we needed to be. It was pretty dramatic how within an hour or two, we managed to completely reverse that to saturation, and eventually able to. But this would have been in someone that clearly without improvement, I thought we could have extracted some of that clot again. So again, the decision making here was initially, I felt really strongly that perhaps I needed to take him at that time, but because he looked so good and I didn't have any strain, it was reasonable to give myself a little bit of time. And I think that was the right choice, obviously, in that moment. So who to consider for surgical embolectomy? As Chris suggested, obviously the massive pulmonary emboli, in which we think these are reasonable surgical candidates, or thrombolytics may not be or are contraindicated. Deteriorating submassive PE, as we've just talked about. Really, assessment of the right heart side is really important. So big, large clots in the RA and RV are really something that are pretty scary. And in my mind, are actually contraindication to thrombolytics, because you're just going to free them to go where you don't want them to go. Clot in transits, or large thrombus across a PFO, for example, which I've never seen, but certainly is conceivable. Shock, resuscitated arrest, ongoing CPR. These are all the things that we might consider in these patients. So the algorithm, as Chris pointed out, is really quite nice, this algorithm, because it really takes you down the pathway of somebody with hemodynamic compromise, either massive or intermediate risk, and really sort of go down the pathway of trying to assess these patients and really decide on how to proceed. But it does highlight that these intermediate risk patients are sometimes difficult in terms of sorting out who's going to benefit, who's going to respond to treatment or not. And consideration for surgical pulmonary embolectomy can occur in many parts of this algorithm, as I'm pointing out here. Ultimately, the decision-making is really around antifibrinolysis or fibrinolysis, catheter-based embolectomy, which, there probably is a role at some point, but it's certainly my interventional radiologists that do this sometimes, but their efficacy with very large thrombus burden is hard for them. And this is where surgery can be quite helpful. I think what's most important is for us to consider always in these patients, making sure that we have a system in which we do a multidisciplinary assessment, and we do make decisions, as Chris pointed out, the ER physician, the ICU physician, interventional radiologist, and the cardiac surgeon, what are the risks and benefit for these patients, and how can we best optimize the best treatment? This is really what's key. And I think in the next slide is really that intermediate group of patients that is really hard to assess. If they look well, then maybe you do have a little bit of time. Vital signs are very important, but you need to look at biomarkers. You need some imaging, and the imaging of the right side is really important. Some echo and CT can be quite helpful in providing cues or clues on how that right ventricle looks. Certainly the type of patients that for me are frightening is when you see this patient that's bolt upright in bed, tachycardic, with tachypnea, and they've had a massive burden of clot, and they're just on that edge for dying. And those are the frightening patients. And then those are the kind of patients that mechanical support would make more sense in those, that any therapy you're going to do, even prior to intubation sometimes. So what are the take-home messages? My sense is pulmonary emboli and submassive is likely more common than we think in our practice. Just our failure to recognize sometimes. I think imaging and clinical evaluations are key to diagnosis, as we pointed out. Signs of right ventricular compromise do include a variety of things, including clinical exams, so blood pressure, heart rate, biomarkers, general appearance. All those things are really part of the gestalt of when you assess someone. And a multidisciplinary approach is likely best for the treatment of submassive PE. And it just illustrates that not all pulmonary emboli and DVT, when they present to the emergency department, are just, you put them on anticoagulant, you let them, they'll be fine. I think there is subsets of these patients that can deteriorate and get into trouble very quickly. Anyways, I'm going to stop there. I think that's it for my slides. And we're going to initiate, stop the share.
Jeff, could you maybe comment on the technical aspects of operation in terms of it actually being a hard operation for surgeons or not, or if the surgical risk of it really just depends on the patient?
Yeah, I mean, technically, there's not. Being on bypass and circulatory arrest, there's a few little tricks to it. It's not a difficult operation from a technical point of view. The problem is really around patient selection. In patients who have chronic clot burden and right ventricular dysfunction, you may end up in a position where you'll have difficulty coming off bypass and have tremendous right ventricular problems. So it's really choosing the one that you think is going to benefit from your intervention. And as Chris pointed out, in the best sort of surgical series, the mortality risk in that patient group is still in the 8 to 15%. Like, it's not negligible, but you'll include in these patients post cardiac arrest. Like, there is a sick group of patients here. But I think, there are patients clearly who can benefit, and it's really important for us to think about it. And certainly the goal of these rounds is really to sort of heighten the index of suspicion for people, and then for people to think outside the box a little bit, that maybe there are other people who can help you in sorting out these patients and who might benefit here.
Yeah, and Colin, what JF highlighted, which is a really important point, is there's a very large distinction between an acute PE and your ability to open the pulmonary artery and pull out the clot versus chronic thromboembolic pulmonary hypertension and a pulmonary thromboendarterectomy. The latter is a completely different operation that is done well in a handful of centers in the whole continent. So those are the people we really are avoiding, and those people should be, are identified in an elective setting and referred on to a PTE program in Canada. That's Toronto. These are really the acute PEs with concern of the potential for hemodynamic collapse or deterioration that we're talking about. It's a very important distinction.
Thank you.
I've got a question here from so patient number 2, the cause of PE was not obvious. Do you know if she had the COVID vaccine within a few weeks? A presentation? No, her COVID vaccination was quite a long time prior to that, if I remember correctly. And from a scan point of view, there was no suspicion of malignancy there. Having said that, there was a little bit of concern from Chris and I that maybe there was a little bit of chronicity to some of the findings. Maybe not months, but maybe weeks to our problem, because there were certainly some areas of the pulmonary tree that were very hard for us to extract the clot, and whether or not those days was enough, or I'm not sure, and maybe explains a little bit of our findings from a surgical point of view.
I think what amazes me is looking at these CT scans is you can have 3 CT scans that look almost identical in terms of clot burden, and you can have one person who is sats of 70 on 100% FiO2 and another person that's on room air, despite a very similar radiographic appearance of the clot burden. And it's amazing to me how the physiologic impact of the clot can vary dramatically from patient to patient, which I think really highlights some of the challenges around decision making.
Yes, that was really the main goal for us to present this, is these cases just on a purely visual point of view look very similar. And our colleagues from interventional radiology or radiology in general who see these clot burdens all the time, it highlights how this is a lot more common than we think. And it's the clinical scenario that really matters around this, and highlights that. I think that's all for the questions we have. I want to
Sharif has a question, Jeff, if we have a minute.
Yeah, go ahead, Sharif. Join in.
Thank you very much for that. So what I guess my question is, here being in a peripheral site, when should we contact you? Because we struggle enough just with the decision of whether or not to do thrombolysis or not, especially with those kind of in between softer blood pressures, a bit of RV dysfunction, should we not, and so forth. But when is it that, we should get on the phone and say, hey, should you guys be aware of this patient? The reality is that I'm assuming that if they get worse, they're in the wrong center. And I don't want to be transferring all these patients down to you guys, because that's just going to be way too many, because very few of these are going to actually have that really bad decompensation that would require your services. What are your thoughts on that?
Yeah, my thoughts are going to be the ones that have really, so for one is, I think it's never wrong to give a phone call for us to look at the imaging, because there is a certain art to us looking at the imaging and looking at, is that actually something I could extract? So that's one question. And then 2, getting a bit better idea of the scenario. There are clearly some patients that they have tremendous clot burden, but it's quite distal. We would never be able to extract that. So that's one part. The second part is really around, I personally like better knowing early on these things and see how things manifest themselves than late when you're actually too far down the line. So, but that's a personal opinion. I wonder if Chris can comment on some of those things.
Yeah, it's not an easy question, Sharif. I think the person that you look at and makes you uneasy to look at is the person that maybe is worth transferring. As Jeff pointed out in the presentation, the person that's, sitting up in bed, sinus tach at 110, blood pressure is okay, but borderline, they're tachypnic. That person, I think, is the one that has the potential to decline, and probably early transfer is better. The person who, is talking and looking around and has a heart rate of 80, and doesn't look unwell, I think those are the people that probably do better. But I think the decompensations can be hard to predict to some degree, and I know what Mark Tushka does here. If he doesn't think they warrant thrombolytics, as an example, is he has the thrombolytic drawn up at the bedside and sitting there next to the bed, and leaves instructions that if things start to decline, that it's ready there, ready to give. And so, I think in the people you're worried about, I would say then thrombolytics and transfer potentially, or call thrombolytics and call. And if you don't think they're bad enough to need it then and you're transferring, then to send them with a dose of thrombolytics in the ambulance that can be given if it should be required. But I don't, I think the short answer is it's probably hard to know who those people really are. But I agree with JF that being able to look at the CT, there are some people that, you clearly won't be able to help with an operation. And then the protoplasm, if they're a young, otherwise healthy person that we would do everything we could to salvage, that's different than a 76-year-old with cancer as a cause for their pulmonary embolus.
Perfect. Thank you very much, everybody, for attending rounds this morning. I'll close the rounds, and next week we're reviewing our ACLS protocols, particularly pertaining to post-cardiac surgical patients. Sue Morris is going to help us with that. So looking forward to next week. Thank you.